Dr. Vivekanand is the first one to present. His topic is endophthalmitis. It's already on the screen. So you have some other talk, right?
Yeah.
Yes, so you can go ahead. Thank you, sir.
So, good morning, everyone. So basically, today I am going to present a work which is, titled as Endophthalmitis After Pediatric Cataract Surgery, a Clinical Profile and Visual Outcomes. I do not have any financial disclosure for the slides which I am going to show here. So as we all know that, endophthalmitis is a potentially devastating condition with a poor anatomical and functional outcome. If you look at the onset, it could be an acute and, the delayed or a chronic onset. So what are the classical clinical features in acute onset? It is usually the rapid onset of vision loss and pain that they present, marked intraocular inflammation, and more virulent organisms that are responsible for causing acute endophthalmitis like Streptococcus species as well as the gram-negative organism. So as you see that pediatric endophthalmitis is a rare but a serious complication that might result from trauma, intraocular surgery, and systemic infection. So the incidence of pediatric endophthalmitis after anterior segment surgery has been quite varied range. But if you look at the Indian context, the Agarkar et al. Have a only publication which talks about the incidence which range from 0.38 to 0.45% of pediatric endophthalmitis exclusively following the pediatric cataract surgery. So how is the pediatric endophthalmitis different from the adult? So basically the innate immunity and the alteration owing to the syndromes or metabolic disorders in children that makes a huge difference. The ocular commensal bacteria in children also differs because anaerobic organisms, they keep on increasing with the advancing age. Children are often not able to articulate their symptoms and often present later in the course of the infection compared to adult. The suture related endophthalmitis is more common in children. That's what we had our own recent publication where the series of 12 patients, they had 8 patients who are because of the suture related infection. So the rationale and the purpose of this particular study is, till date, the literature on pediatric endophthalmitis after cataract surgery is scarce, and to study the 12 children which we came across over a period of almost the decade to look at their clinical presentation, clinical microbiological profile, and what are the predictors of final visual outcome. So these are the primary and secondary objectives. The study was done at Miriam Hyman Children's Eye Care Center, MTC campus, LV Prasad Eye Institute, Bhubaneswar. It was over a period of 10 years from January 2012 to December 2020. So the study design was a retrospective chart review and appropriate statistical methods were used to analyze the data. So a standard clinical workup, treatment and post-operative care in the form of IOAB, vitreous biopsy, and as and when required pars PPV, those standard procedures were performed, and the microbiological evaluation was done in terms of microscopy by using various stains, culture, and sensitivity. So if you look at the results, the mean age and this cohort was almost 10 years with the standard deviation of 5. The males were predominant, and majority of these patients they were from a rural background. If you look at the clinical presentation, the chronic and delayed variety was more common in this cohort compared to the previous literature and what we assume usually they present with as an acute endophthalmitis. But it seems to be the pediatric endophthalmitis is presenting as a chronic or kind of a delayed endophthalmitis. So if you look at the clinical features, I think the redness and increased watering followed by the pain is the most common presentation. And if you look at the sign, lid edema, conjunctival congestion, and then later on, like antechamber reaction and hypopyon are the important predominant signs they do present in a clinic. So what are the possible predisposing factor? So this is quite interesting. The kind of setup we practice, it is full of children with, the tribal population. So probably this is one of the commonest predisposing factor, that is poor compliance to medication plus poor ocular hygiene, then followed by the trauma. So what is the microbiological features? I think 50% of them didn't grow any organism. So they were all culture negative, endophthalmitis. And Streptococcus pneumoniae was the commonest organism that was seen in both the groups when we cultured from the scraping as well as vitreous biopsy. So more number of bacteria were isolated in culture from the vitreous sample as compared to corneal scraping. So this is also something interesting compared to the adult endophthalmitis. So bacteria's came out more from the vitreous sample compared to the corneal scrapings. Medical management, intensive topical steroids, antibiotic and mydriatics. Surgical management, you can see that the most common intervention done was IOB, followed by vitreous biopsy, and as and when required PPV. So if you look at the outcomes, there is an amazing trend. If you see the median interquartile range, or even the mean with standard deviation, you can see that at presentation there was a gross loss of vision. However, they have shown a very good outcome at final follow-up visit. So it is contrary, like in children's, probably the outcomes are better when you actually treat them at appropriate time, and that is shown to be statistically significant. So discussion, the overall rate of endophthalmitis during the study period was 0.28%. If you see the published literature by Irwin, Shader or Good et al., it is ranging from like 0.1% to 4%. And why these differences? Why there is a big range? Is difference in demographic parameters?
Quick.
Yes, so I would like to what's new in this particular study. Streptococcus pneumoniae culture positive endophthalmitis is almost 50%. Delayed or late onset endophthalmitis is common in children, and suture related postoperative endophthalmitis is a slow onset caused by low virulent organism and has a good visual prognosis. Thank you.
Hello. As you said, the cause of the endophthalmitis is more suture related. So what I do in my practice, maybe you can also think about it, is the pediatric cataracts are very, very soft. So I do not enter with I do not use the keratome at all. So I use the two side ports and complete the surgery through the two side ports. Next comes the IOL insertion, is a very tricky thing. I think there are some new IOLs which are going through a very, very small incision, maybe slight increase of the side port, and if you make a little longer side port and you can push the IOL through that, you may not need a suture at all, and if you hydrate the side ports quite well, and that completes your surgery. Thank you.
I think a lot of literature is coming up in a journal like JAPOS, where even pediatric age group now people have started doing sutureless cataract surgery because of these complications.
Which were the IOLs usually used in these
cases? So these are all like single piece Acrisoft hydrophobic IOLs. They're all high quality IOLs.
Okay, so you needed around 2.5 2.8 incision.
Yes, 2.5 2.8.
So you need a suture, right? The 50% which you said you could not grow the culture, you thought of
it
means the culture came negative.
Yeah,
right?
Culture came negative.
So could it be a sterile type or TAS type of thing? There is a chance.
See, usually what happens in our institute protocol, so we follow all these patients who are taken ground-like culture up to 4 weeks, and we label them as a negative. It doesn't do anything after 2 weeks. So till 2 weeks, we still try to look at and then correlate clinically. So what I remember, most of these patients, because they are all institute poly, so every endophthalmitis is documented very thoroughly. Even the video recordings were done for all. So none of them had a kind of feature of TAS or something like that.
But the one you gave negative was till 4 weeks negative.
Yes, all 4 weeks negative.
Okay.
I am not sure they're related to your study or not. Treatment protocol, culture negative and culture positive, anything different?
As far as outcome is concerned, I think...
No. Treatment wise, treatment protocol. Culture negative?
No. There is no difference. We usually follow the same protocol.
Same,
IOAB,
culture positive, yes. Or culture negative?
Yes.
So did you find any outcome differences at the end, culture positive and culture negative?
More or less, if you see the the visual acuity improvement, majority of them recovered with better than 20/200. That is how this pediatric data seems to be something different. Otherwise, usually the Streptococcus pneumoniae happens acute onset endophthalmitis. These patients were presented late. Despite that, also very well managed on a intensive medical therapy.
But the outcome was same.
Only 2 patients had to take a pars plana vitrectomy or.
No, his sir is asking outcome was same whether culture negative or culture positive.
It was same. It was same.
There are no statistical differences.
No statistical difference.
All right.
Yeah.
Okay.
And one last question: are the sutures removed? Because we found that it was suture related.
We presume that it's 10-0 nylon.
No, sutures were removed in most of the suture related endophthalmitis. 3 cases that we
No,
had
suture
in this
related
series.
you will remove. My
Yes.
question is the other way. If we feel it is the suture, and if we feel it is coming on a chronic basis, means even later on. So the pediatric patients who didn't have real endo, are their sutures intact or they are
that were the
removed?
situations, where they were lost to follow up.
Okay.
And we couldn't come, they couldn't come on, the standard protocol, which we usually remove all sutures 2 weeks after the first surgery.
After 2 weeks.
First surgery, then second eye next week, and third week, both eyes suture removal.
And what is the average age of the patients, those who are?
That was 10 years. The mean
10
age was 10
So
years.
You
By this time, they develop some amount of amblyopia. That's why maybe the 200, 2 by 20 by 200.
Very unlikely, because the highest age, the duration after, the surgery was done was 29 days. So I don't think like 1 month being like low vision and
is going to.
causing the, endophthalmitis leading to the amblyopia is very unlikely.
Comparing with the normal group.
Oh, that would be always a bias, because there could be a plethora of like developmental cataract or pure congenital cataract. So that would bias the actual visual
All
outcome.
right, thank you. Because it is outside the purview of your
Yes.
study.
It's-
And
yeah.
There are a lot of questions out of it. Comparing this one with the normal things, visual outcome.
Yeah,
You said it is 2 by 200, but what about the normal eyes?
yeah.
Non-endophthalmic eyes. Who is next?
Fine. Yeah.
Thank you.
Thank you. So I think now we go as per the order.
I think number 1, Dr.
Yes.
Jebinath is not here.
Dr. Jebinath is not there. Okay.
We have been.
So first is not there. Third one was big one. Third done. First
Third
is
done.
not there. So
Second
now
is
we it's
Yeah.
Dr. Supriya Samak. Her topic is safety and clinical outcomes. You are Supriya, right?
Yes, ma'am.
Yeah.
Good morning, everyone. My name is Dr. Supriya Samak Ganesh. Thank you to the esteemed panel for this opportunity.